It's
This
Tuesday.
conference will now be recorded.
It's Tuesday, February 11th. Welcome to the AnCan virtual support meeting for high risk, recurrent, and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderator Gwen Sierra, maybe John Antonucci. Oh, here he is. Here he is.
Yeah, I'm here. Yeah.
And Sierra. John Antonucci is on his way, and Rick Davis, the founder of AnCan. No matter how much we sound like we know what we're talking about, nothing here is medical advice. Funding for this meeting was supported by these companies: Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, and Blue Earth Diagnostics, which doesn't deter us from calling them as we see them. So we have a new participant tonight, and that's how we start the meeting. Now I have to. That was Wes, right?
Truth in advertising. I think I actually showed up. Rick was here. I didn't know anything about a month ago, but I am now, no kidding, aggressive for treatment here shortly. So you call him as you see fit as a moderator.
Well, the question is, did Rick do the shakedown? He asked you your age, your
Yeah, he asked me out for an evening, but I declined.
I can't
yes,
see why.
Rick,
You're lost.
I mean, and Rick, I do have to acknowledge that you observed I was at Scripps Institute. I did move over to UC San Diego. It is better in all sorts of ways.
Remind me, if you want to put it in your chat window, remind me of your last name.
Danskin is for
yeah,
anybody's.
that's right, Danskin. I think we did an intake.
Correct.
And let me just check. I'm pretty certain I did. That's right, because the Danskin certainly rings a bell. And yes, we did an intake, so you can just give Wes some time to update us, and I will send you my notes in the chat window in a message.
Okay. And since it looks like a light load tonight, Craig Christensen, would you like to speak tonight?
I don't think I need time. Thank you, Ben.
Okay.
Okay.
So first on the list is Dan from Virginia.
Don't lose Wes along the way, because you had him down as a new man. So stick him in as an old man, but he's not really an old man. So even if he doesn't, even if he denies my advances, he's still not an old man. Okay, I'm sending to the organizers. I'm sending my notes on Dan right now. There you go.
You mean Wes? Rick, you mean Wes, right?
Yes, Wes. No, what I meant was, don't miss Wes out. Don't miss Wes out, because he's not a new man, because he has an update for us. That's what I was trying to say.
Yes, thank you. You know,
it's very challenging for me today, because there's so much going on this week, as Ben will, and not only am I challenging myself, I'm challenging Ben as well, which I'm sorry, Ben. But anyway, yes, go ahead, Ben.
So Dan, you were saying.
Well, I was not rudely interrupted, but just slightly. I've been on ADT now for about 9 months, and since January, the beginning of December, all of a sudden these side effects really started to crop up. Swollen ankles, obviously swollen face here.
Yeah.
And incredible pain in my hips that or today I got a bone density scan. It is osteoporosis and osteopenia, but the big issue is uh, the significant increase in blood pressure. And I've talked to Jim, and I've also talked to my PCP and sent an email to my uh, oncologist today asking to get a variation off the ADT that I'm on. I just wanted to see if anybody else has had these same kind of side effects as they've gone through the process.
Robert, that sounds like you.
I haven't resolved them myself yet. I don't have the high blood pressure, but it was all the bad joints and stuff. But and the osteopenia. I started walking and kind of increased the over the counter meds for the pain, and just kind of been going through it.
Uh,
Hey,
I
Doc.
was I was a
Sorry.
runner every morning, and all I can do is walk now.
Hmm. I could never run.
And what
So the doc.
medication?
Oh yeah.
What
Go ahead. Sorry.
medications, Robert?
Pardon?
What over-the-counter medications were you taking?
Uh, just uh, like Advil, or I can't remember now, just over the counter stuff like that.
Uh-huh.
Um, and I do use marijuana, and that does seem to help my pain as well.
Great.
It's
Excellent.
illegalized here, so
Gary has his hand up.
Yeah. Um. Actually, Rick has his hand up first.
Yeah, these are very common side effects from being on androgen deprivation therapy, Dan. Um, very common. The swelling, I can only speak from my case, and the docs may correct me, but the swelling that I had was all from fluid retention, and I'm suspect which is definitely a side effect from being on the ADT meds. So I'm
Yes.
suspecting that the fluid retention that you've got fluid retention. Um, the high blood pressure is also a result of the ADT. I went on lisinopril. I had never been on a blood pressure med, and I went on lisinopril. Actually, they put me on uh, lisinopril and hydrochlorothiazide, but I did not react well to the hydrochlorothiazide and dropped it. Just stayed on the lisinopril. This was all handled at Kaiser because I was mainly a Kaiser patient as well as UCSF, but my everyday care was Kaiser, so Kaiser did all of this. Um, they should know well enough how to help you with this. I mean, certainly with the retention issues, with the water retention issues, which are probably why your ankles are swelling. Suggest that. Ask them to check. Ask them to put you on a BP medicine. The joint pain too is very very common. Um, so what I would say to you is, don't be too concerned. I mean, it's easy for me to say, but I was there. And yeah, you think, oh my God, I got metastasis and this and that, and the other. But these are really, I mean, everybody's different, but a lot of people suffer with these same side effects. With that, you got three other guys that
Yeah.
want to comment on this.
Can I
Yeah.
follow up, Rick? One of my thoughts that I passed on to Dr. Farrar, my oncologist, was whether I should step off the Lupron and just do monotherapy. Do you think that's a good idea?
I would try and how long have you been on the ADT?
Approximately 9 months.
Yeah, I would try and tough it out for a while longer. I mean, if has she put you on a blood pressure medicine?
No, but my PCP is
Okay, so
wealthy.
I mean, but you see, again, she should be doing it because she's the one that's in charge of your ADT.
Mm-hmm.
So this isn't for your PCP. This is really for her to be addressing because these are side effects of the ADT. And if she isn't smart enough to understand that, we got to get you a referral out to somebody like Channing Pala. And this is why we always try to get people to GU medoncs, but it's very hard at Kaiser. But the Kaiser docs, if they cannot handle it, they shouldn't be throwing it back on the PCP. The PCP certainly, it isn't their area of expertise. And this is what you got to be saying to her. And you got to again advocate for yourself in this. I mean, if she's not addressing the fluid retention, which she should know comes with, I mean, when women go on menopause, it's very common that they have all these extra fluid retention issues, and you're going through the same thing because your hormones are being suppressed. And so they've got to address those fluid retention. She's got to address these fluid retention issues. She's got to address the high blood pressure. So would I say come off of it? I mean, this is probably where we got to defer to a Dr. Jeff or to Dr. John, or Dr. Jack, but I don't know if blocking the receptors is going to do the trick and allowing testosterone back in. I just don't know enough to know if that's doing it. But I would say hang in and get on some blood pressure medicines, get on some diuretics if need be. How much weight have you put on?
Approximately 8 pounds.
Which isn't bad. I mean, I went from the low 150s all the way up to 169 over that 2-year period, and it was mostly all water.
Mm-hmm.
It wasn't really around my gut. I was exercising every day, but I would keep putting on the weight because my body retains water and lets go of water even now on it. So, that's how I am. Anyway, let's move on to the other guys who want to talk.
Yes, Gary Peters.
Dan, what is the other drug you're taking besides Lupron?
Oh, Abby and prednisone.
Okay.
Abiraterone and prednisone.
And how much prednisone?
Just 5 meg.
Yeah.
So I took the same regimen, and all those things happened to me, and I was already on blood pressure medicine.
Mm-hmm.
And some of those things I know happened to Dr. John, and he actually had to stop the abiraterone. Fortunately, I was able to get through those for about a month, and then they dissipated. But you might want to talk to your doctor also about upping the prednisone to 10 milligrams, because that's not uncommon for men who are taking this. But everything you listed was something I dealt with.
I never even thought of increasing the prednisone. Why would that be? Could anybody comment on that?
Yeah, anyway, I can, because of fact in excuse me, in about 2017, I started out with 10, okay, and it was the recommendation at the time, and then in about 2019, where the recommendation dropped for the castration sensitive down to 5. But anyway, I was on the 10 for about 2.5 years, and that was fine. Anyway, hypertension, though, mine started all the way back in 1984, And so, I happened to get on the drug, and abiraterone. And just prior to that, hypertension was really bad, and they put me on to hydrochlorothiazide along with atenol, which is a beta blocker, and lisinopril. So I was actually taking 3 of them for the hypertension. So I cruised in with the abiraterone, and I was fine. So
Thanks, Jim. Dr. Jeff?
So, Dan, I would not recommend increasing the prednisone. If you increase your prednisone, you're most likely going to wind up increasing your blood pressure even more.
Right.
What I would do is have your doctors put you on a diuretic. It can be hydrochlorothiazide, which is a mild one. It can be something stronger like furosemide, Lasix. Watch your potassium levels, because when you take steroids, you suck in through your kidneys sodium and you boot out potassium. So be careful with your potassium levels. I would stay on both the Lupron and the abiraterone with a diuretic. If the diuretic doesn't bring down your blood pressure, add in a blocker. You could go on losartan, is a very good one. You could go on amlodipine, which is a calcium channel blocker. But you can go on multiple drugs to keep your blood pressure normal while you're on ADT. Again, also, since you said you have osteoporosis, you really should be on a bone sparing medication. Did they discuss something like Prolia with you?
I've already pushed my doctor yesterday, and he's looking at that. That's why he had the bone density scan today, and I'm sure we'll discuss it tomorrow. I already pushed him on Prolia and Fosamax.
One or the other, yeah.
Right.
And remember, calcium, vitamin D
Right.
is also important. But I would not stop the
All right.
Abbey.
Yeah.
Thank you.
So let me just say, you don't really want to take Fosamax. It's a real pain in the butt to take. So either the Prolia is good, or what's the other? What's the injectable? I mean, I got Zometa, which is a bisphosphonate, but which is the injectable form of bisphosphonate? What's it called?
Bisphosphonate?
Yes, there's a bisphosphonate that you get. It's like a 6-month dose. You get it as an injectable. I can't remember. I know it. It's just not coming to me. It's a pretty common. A lot of. What was that?
Exgiva.
No, Exgiva is not a bisphosphonate. Exgiva is denosumab. I'll look it up and I'll put it in the chat window. But what they did for me, and what they might want to do for you, is Zometa infusions, but not on a quarterly basis. I got mine on a yearly basis. But again, this is something that your GU people should be handling, not your PCP, because he's out of his depth. You know, if you start talking to him about, he's going to put you on Fosamax, and you're going to say, well, what about Zometa? Oh, you don't need Zometa. But he doesn't, because he doesn't get it.
Got it.
And you know, so I would say you got to go back to your oncologist and say, hey, you know, I need you to take charge here, Dr. whatever her name is.
Thanks.
Very sure. Your hands up.
How often are they doing blood work on you?
every month.
Okay. Watch those very carefully because that'll tell you if your mineral levels are low or high. My glucose increased quite a bit, and I became nearly diabetic. But I had a good GU medoc that handled it very well.
That's a great comment, Julian, because before my blood test last week, I was really working all last month and a half on getting my cholesterol down, and it really dropped based on what we haven't discussed here. My doctor was very happy. It's just all these other new side effects popped up, and I'm realizing, at least for me and probably for everybody, it's so complex. It's like squeezing a balloon and it just pops out in different areas.
Are you exercising?
Every weekend, and then every day I used to run, but now I can just walk for about half a mile.
It's good. I walk every day.
Yeah, for a runner that doesn't do it, but sooner or later I'll get there. Thanks, Ben.
Larry Schuler, your hand's up.
Yeah. What do postmenopausal women do for these effects, the water retention and all that? Usually it's low dose estradiol replacement. Transdermal patches are safest. And when a man reduces his testosterone, his estradiol goes down too. So replacing that lost estradiol sometimes can alleviate the side effects. It helps avoid osteoporosis as well. So I recommend you talk to your oncologist about that or an endocrinologist.
Mm-hmm. Thanks.
If Markey.
Hey, Dan said he was new, I thought.
No.
No. Oh, okay. I had never had heart problems, never had high blood pressure until abiraterone. I'm on ditalzin, losartan, and metoprolol. And metoprolol was really the best drug to really ease things. And I found out from a cardiologist, a retired cardiologist, that he takes it to prevent AFib or when his heartbeat gets too high. One nice thing about a drug like that is no matter how much you exercise, your heartbeat never gets above about 110. It's a beta blocker, and it just prevents your heart rate from rising. Wow. And I do some heavy exercises at least once or twice a week, and never above 108. So just some things to think about.
Can you put those 3 medications in the chat? Thank you.
Sure. It was losartan was already mentioned, but yes.
So the drugs, the bisphosphonates I was trying to think of were either Reclast or Boniva. Those are the commercial names. But whatever you do, don't get on Fosamax because you got to get up early. You got to be upright with it, and then you got to wait with your food. Although you're doing that with the abiraterone, but everybody I know who's taken Fosamax is never that happy because it's a tough drug. It's a tough pill to take. But so I would go with either the Boniva, the Reclast, or Zometa. The one thing that I was told, and the docs may contradict this, but all of these bisphosphonates are pretty much the same, but they come in different ways to administer, either in pill form or injectable or infusion. And that change influences how much you retain. So you retain more of the infusion, a lot more of the infusion than you do of the pill. The pill, you only retain like less than 5% of the actionable medicine. The injection, a lot more, and the infusion, a lot more over that.
Finally, Wes, you wanted to address this.
Well, this is going into the weeds, but I know more about blood pressure medicine, edema, and gout than I used to. Most blood pressure medicines cause edema. Many cause gout. Most cardiologists and others in the United States don't understand the lymph system very well, except for the breast cancer people. If you go down the path of lymphedema, and in particular lymphedema massage, I found it's very simple, goes very simple. and you can drop your edema by 30% with 20 minutes, or I could. Maybe you can. It's common, but it's not well known. Hydrochlorothiazide is consistent with gout, lisinopril less so. So that, just think of, go down the YouTube path of lymphedema massage. Very efficacious when a lot of other things cause other side effects. So thanks for the time.
Thanks.
Had anyone heard of that? That sounds like a thing worth trying.
Yeah, I've heard of it. It's very, very popular form of treatment for breast cancer, together with certain exercise, which is designed to help the lymph nodes around the chest. I mean, it sounds like where you're having these lymph issues are lower in your body, but again, your oncologist will be aware, or should be aware, of lymphatic issues as a result of being on medicines. So it's another thing to discuss. But yes, I'm well aware of it. And there are certain providers that can help you with massage, just like Wes said. The other thing is, and maybe Dr. John knows more about this. I don't know whether acupuncture can be helpful for these lymphatic issues and water retention, Dr. John?
No,
No. Okay.
I don't know. No, never tried it.
Larry Schuler, your hands up.
I don't know from personal experience how massage can help lymphedema, but it makes sense. If you have slow moving lymph, massage can ease it along. But I'd never heard of any adverse side effects from it. So I think less medicines is more, and the human touch is pretty much accepted to be therapeutic as well. So I would try it.
Yep. Thank you.
Wes, did you want to weigh in again on this?
Some more details will help you. I went to my acupuncturist. I had edema. I was in the hospital multiple times on infections, IV antibiotics, not a good thing, lower swelling in my legs. Then I found out that a lot of this was commingled with my blood pressure medicine. Went to acupuncture thinking that might work. He referred me to a lymphedema person. In Europe, they're well trained. In the United States, there's very little of it except for women's breast cancer. The concept that you need to have that I didn't have is that when your artery conducts 100% of the flow down your leg, how much comes back in the vein? 100%. Wrong. 90%. 10% goes into interstitial spaces between cells and is picked up by a system that's not even called the lymph at that point, but eventually filters into the lymph system and is picked back up. There is nothing but gravity drainage that will do that in the large muscles. So very light touch, not massage it is very superficial. That helps move that through the interstitial spaces. When you take one of the blood pressure medicines, one of the things it does is relaxes the blood vessels and it makes them more permeable, so you actually can have more arterial fluid, blood, flow into the interstitial spaces. The body thinks that that's an invasion. It goes into even more edema. There's a whole cycle there. Like I say, I talked to my cardiologist. He didn't know. He's very good. So it's not well taught. Like I say, just go down the path of lymphedema. As somebody else said, there's no negative that I know of. And I could drop my edema by, like I say, 30% with 20 minutes. I do it routinely. You can just do it wrapping your face like this. And it's simple, should be routine, especially when you have edema that is caused by a lot of the symptoms and a lot of the drugs we take or the inactivity. Thanks for the time, guys.
Thanks, Wes.
Yeah, I would push them at Kaiser because I'm sure they've got a lot of support for the women on breast cancer. I bet dollars to donuts they've got great support for women on breast cancer for this lymphedema, and you probably could use the same. So you got to push her on saying, well, what do you do for these women who have lymphedema? How do you treat them? And she may say, oh yeah, well we have massage for them, or we have acupuncture for them, or we have this for them. Well, I'd like the same, please.
Thanks.
This is a great discussion, by the way, guys. I'm curious who else in this group has has dealt with this type of blood pressure and water retention issues, and how has anybody else treated it? I know a few people have weighed in, but does anybody have any direct peer experience? Dr. Jeff.
Yeah, so you can do something very simple like elevation of your legs.
Right.
We actually got a bed where the feet go up, and 25 minutes a day you lie flat, you raise your legs up, and a lot of that fluid will be returned to your vascular system. The other thing you can do is wear compression socks. And if you go that route, don't buy the cheap ones on Amazon. Buy a bunch of good quality compression socks and wear them in place of
Yeah,
regular socks. They're very effective
yeah,
at retaining at returning fluid out of your feet. And when this happened to me, I saw a vascular guy and he did certain ultrasound tests on my venous valves. And as you get older, the functionability of the valves in your veins deteriorate. And instead of, let's say, them closing in half a second, they take 1.5 seconds, which results in fluid buildup. So some of this may not even be, it may be a combination. You may have some vascular deterioration on top of the medications that you're taking. One last thing, did you get pelvic radiation when you were treated?
Yes, but
yeah,
you just opened up a can of worms. In the back of my mind, I think because I was pushing based on the advice I got here to do the spacer, and the doctor who did the radiation does not use it, and he would not allow it. And I'm thinking there's
No,
damage that's done with radiation.
nah,
yeah.
no. If these are lymphatics that got damaged, these are higher up in the inguinal and femoral
Right,
lymphatics, and I
right,
don't think your doctors irradiated that. They probably irradiated your pelvic nodes
Hmm.
right,
as well as the cancer.
right, right. Um, I would just also say to you, you can probably get those compression socks from Kaiser as well.
I'll
Oh,
bet you
really?
can.
Ask for them at Kaiser, and it won't cost you anything. I think we got to move on. I'm
Yeah.
concerned about time, Ben.
Yeah, fortunately, this is a light night. Um, Dan, also, you see there's quite a bit of discussion in the chat.
Yes.
So I hope this comes close to answering your question.
Yes, definitely. Thanks so much for the time.
Gary V, you're next.
I have a question about the estrogen in lieu of Lupron, Orgovix, basically the Viveldot patch in conjunction with Zytiga. How many people have discussed this with their doctor, if they have, or how many people are considering it?
Yeah.
Because I'm definitely considering it. I'm not on ADT at the moment, but it's highly likely that I will be back on ADT soon. I've got a PSMA PET scan coming up. I've been off of ADT for over 2 years now, and
Gary, are you new to the group? I don't.
yes,
I thought you were. Yes.
Ah,
Not such a light night, Ben.
yes, yes,
You want to do an induction?
yes. Gary, I am sorry. That's right. I completely forgot to ask people if they were new. Um, Gary, welcome. Appreciate your coming. Um, I will ask a few questions and then we'll get back to estrogen. Where do you live?
I'm in Portland, Oregon.
And how old were you when you were diagnosed?
I was diagnosed just before my 75th birthday.
What year was that?
That was in 2000. I mean, excuse me, 2020. years fly by. It was the end of 2020 when I was diagnosed.
What made you think you had prostate cancer?
Nothing. I thought I had a prostate infection, and went to see. I've had prostate issues for a good part of my life.
Hmm.
My and generally my PSAs had stayed under 4. And
Hmm.
when I saw my primary care doctor, my PSA had gone up to about 6 or 7, and we tried a course of antibiotics, and it was unsuccessful. And I went to see the urologist. I had a urologist at UCSF, and my urologist examined me and said, "You've got a lump on your prostate, uh, and your PSA is going up. So let's get you over to an oncologist." And so my journey started. And basically, my PSA, the highest my PSA ever went was to 15.7. And they did not think, based on my PSA, that I had very aggressive disease. I had a PSMA PET scan on January 4th of 2021, and they found 7 mets outside of the prostate, bones, and lymph nodes. And I started on Lupron, and then went through radiation with Dr. Roach at UCSF, and stayed on Lupron and Zytiga for approximately 2 years. Moved to Oregon in the meantime. Was treated for a short period of time at UCLA. I lived in Newport Beach for about 10 months, and then was treated at OHSU here in Oregon for a while, and now I'm at Compass Oncology. The program at OHSU is prostate cancer program has pretty much fallen apart. So I have my primary doctor is Dr. Roach at UCSF, and I have an oncologist as well as a radiation oncologist at Compass Oncology right now. And my PSA is on the rise again. I had some the last PSMA PET scan that I had back in June. They found a couple of spots in my chest. Those were irradiated in September. So my PSA now is at 2.97 as of December, and the doctors at Compass wanted to wait for me to do um, a few months after radiation before they wanted to repeat the PSMA PET scan. Dr. Roach said you need to get a PSMA PET scan right now, so I'm doing that, and so I've read a number of articles on the benefits of doing the estradiol patch versus Lupron and Orgovix. So I'm very interested in doing that to avoid the side effects, primarily the brain fog, the exhaustion, the weight gain that were associated with Lupron in the past. They do not seem to be as significant with the estradiol patch. That's where I'm at now.
Thank you. Larry Schuler, you want to weigh in?
Yes, I've been using estradiol since April of 2024. I sent you a message in chat with my email and phone number. The study, one of the studies you've seen, is it the patch study in the United Kingdom?
Yes.
Yep, that's very compelling and convincing. You know, they've completed the study and presented at the European Society of Medical Oncologists this September. And I don't know when they're going to publish their final findings, but there have been a lot of preliminary findings out there. But I've been using estradiol alone since October, and my PSA is consistently below 0.020. Currently, it's 0.015. I had a prostatectomy in October of 2023. But if you want to know any more details, shoot me an email.
Okay, thank you.
You're welcome.
Jeff Markey?
Just a quick point. If have you had hereditary testing, genetic and hereditary testing?
Because of you, Jeff, I did. The reason I'm in this group right now is because you recommended it.
Okay.
I did have the.
You don't
I did have the
BRCA2,
color.
do you? Do you have BRCA2?
No, I don't have BRCA2.
Great. That's the only.
No, I don't have any genetic. I don't have any genetic defects that would be associated or are currently associated with prostate cancer.
Yeah, there is a problem with the estradiol patch and BRCA2. They don't work together. In case anybody else.
That's true.
So I'm a little concerned about one thing here. You mentioned that when they did that PSMA in 121, there were 7 metastases. Is that right?
That's correct.
And Mac was treating you, and what did he do? What treatment path did Mac do?
Mac did. I basically he said you're going to use all 3 of my. He said you're going to use all 3 of my machines. He said we're going to tomography. We're going to do CyberKnife, and he did IMRT. My last session of radiation was here in Oregon, and it was IMRT for the spot under my clavicle and lymph node, and one down in my hilum and my right side.
So he did originally SBRT and IMRT across your pelvis, and then
Yes.
you had spot radiation to 4 spots.
Yes. No. No. I had 7 spots outside of my prostate and pelvis.
I mean, see, where I'm having a problem is that if you were diagnosed de novo metastatic with 7 spots, I don't know why he didn't do chemo, unless it was discussed and it was something that you didn't want. But the protocol for 7 metastasis is triplet therapy.
That was not his protocol at the time.
I know Mac very well. He was my doc, so I'm real familiar with him. And unfortunately, we didn't talk to us, but we would have said, well, why isn't he doing this? It doesn't add up to me. How many metastatic spots do you have right now?
Well, I'll know on the 20th, but as of the last PSMA PET in June of 2024, I had 2 spots, 2 very small that were even questionable, but they said let's treat them, and so that's what they did.
So Gary,
Roach took me to Tumor Board after my last PSMA. And what came back from tumor board was, let's irradiate the spots. Let's see what happens with your PSA. And if your PSA continues to go up, then we will consider putting you back on ADT.
So this, when you say your last PSA, this was back in June?
No, my last PSA was December.
In December. They don't really have tumor board at UCSF. I mean, he may call it that. They just talk with each other, and it's, it's less formal. But to me, the first thing I would want to do is you need I love Mac, and he saved my life. So I have nothing bad to say about him, but I also know Mac. And for me, I would have a GU medoc on board, a GU medical oncologist on board. I mean, have him set you up with with Rahul Agarwal or Terry Friedlander, or one of the better GU medoncs there, and start talking with them, because with 7 metastases, I wouldn't want Mac running my care. It's not his field. It's not his area. If you had 2 metastases, yes. But with 7, it's beyond what he's trained to do. Now, he may have ideas on how to do it, and that might be why you're wrestling with it now. But I don't get it. It doesn't. It's weird.
Something. Well, he referred me to Dr. Koshkin, and so Koshkin was handling my care for the time that I was in the Bay Area. And then
who's Dr. Koshkin?
Koshkin is a GU at UCSF.
I don't know. He's not one that I know. Is he a younger guy, relatively?
Yes,
recent?
He's a younger guy. He tends to be pretty aggressive.
Okay.
But Roach has kind of been my go-to for. I mean, I'm alive, and I look at that.
I get it. When I see Mac, he thumps me on the. I'll see him this week, and he comes up to me and punches me in the shoulder.
He does the same. Yeah, I haven't seen him for a while physically, but we do this over the video thing. But yes, he does the same. We're on very good terms.
I know, but yeah. I think you need a GU medonc. And you're now in Portland, so what's her name? The Russian lady.
Sokolova.
Huh?
Sokolova, she's worthless.
She's not great, but she's not worth. I wouldn't say she's worthless, but she's not great. I'd have to agree with you. She's young. She's young.
Well, yes, but when I went to OHSU, I started out there with I can't remember her name, but I ended up with Julie Graff, and Graff is very competent, very together. But Graff took off from the program, and basically the only one there that right now is Sokolova.
I know.
But anyway, Sokolova said very, very clearly to me after my PSMA scan that I had 2 spots on my left side, and that the recommendation from her radiation oncologist was not to irradiate, but to just put me back onto ADT. The bottom line is that the spots turned out to be on my right side. They misread the PSMA PET scan, and both Roach and the doctors at Compass caught that misread, and so I lost total confidence in the program at OHSU. So
I know a little bit about what's going on there, and I get it. The Ung is not bad. I'm a little nervous on Sokolova because she's young and she's inexperienced, and they don't have it. But for me, I would want a competent GU medonc, and that would mean going out of the as Mark Valens will tell you, who is a relative neighbor it means going out of the area and going to either UW or UCSF or UCLA, but it's your life, and I would say it's worth it. So, I wouldn't be. You need a really good GU medoc on your team alongside Mac.
Yeah, I would absolutely love to have that. I'm also considering at this particular time, my wife and I are considering moving to the Western Cape of South Africa. So I've been looking into physicians in that area that are GUs, and would appreciate any information that any of you might have or might know of associated with that.
I don't. I can't. That's out of my league. I'm afraid I can't help you with a South African GU medoc.
I thought the sun never set on the AnCan empire.
Well, I'd have to, I'd have to ask around GU ASCO this week and see if there are any South Africans there. If I hear any South African accents or I see anybody from South Africa on the posts, I'll make sure I make a note of them, Gary.
Okay, thank you. They have a very active prostate cancer foundation down there.
Okay.
There's a good group down there.
Okay. Have you signed up? Are you on our database? Did Jeff Marchi tell you that you need to sign up to get our reminders?
I don't think I am.
Okay. Well, if you put your chat, you can put it in publicly, or you can send it just to me by clicking that down arrow and picking me or picking the organizers, and just put your email in there, and we'll make sure we get you signed up.
My email's in there now. It's for everybody.
Oh, okay, for everybody. Okay.
And one final question on behalf of Captain Marshall: are you a vet?
No. No, I missed out on that. I was
the other thing that
I was working for a police department during the Vietnam War.
the other thing that I'm surprised that never got done by Mac was that with 7 metastases that he didn't sequence you. Have you ever been sequenced? Had your tumor sequenced?
Oh yes.
Okay, so what I'm not talking about germline. I'm talking about the tumor. What mutations, if any, do you carry in your tumor, somatic?
They showed none.
None. And when was the last time you had that done?
That was done when the biopsy was done in November of 2020.
Yeah, but it should have been done when they found the 7 Mets. So, I mean, this is something different. I don't know if you're talking about something like a Decipher test, but this is sending it off for somatic testing to somebody like Tempus or Foundation Medicine. It's called
they did it at UCSF. Right after the biopsy, they sent it for the somatic.
Okay, well, if it was done then, it should be done again now, because it can change over time, and we're 4 years later, 5 years later. So we need to get you. What did you say your current PSA is?
Current PSA is 2.97.
Get them to take some blood tomorrow and have them send it for a liquid biopsy before you treatment. You'll probably get a result with 2.97.
Okay.
And let's see if you've got any actionable mutations in there. Okay.
Okay.
That's a big one. Tell Mac, you can write Mac and say Rick Davis said, how about a liquid biopsy?
Okay.
And that's sure to get him to roll his eyes and punch me twice. Again, this is why we want you with a GU Medonc, because your people at Compass should be on top of that.
My people at Compass are young. They're good, and they respond to me much better because I have Mac Roche.
Yeah, but these are in the guidelines. These are in the NCCN guidelines. This is not. We're not telling you to do anything that is out of the ordinary. These are guidelines, and the doctors are not following the guidelines, and it's driving a lot of people crazy. There's a bunch of posters coming up about people that should have been tested and haven't been tested. You may have I'm not saying you do, but you may have a brachysomatic, and you may be a good candidate for a PARP inhibitor, and in which case maybe we don't want to put you on abiraterone right away. But this is why we have to do these somatic tests, and we do them periodically. Originally, it was once in a lifetime. We went back to Foundation Medicine and said, no, you got to approve this more than once on Medicare, and they did, and the insurance companies do now, and that's why we do it, because things can change over time, Gary.
Mm-hmm. Yes, I understand that.
Thank you, Gary.
You're welcome. Thank you.
Wes, you're up.
Thank you. Yeah, this is always very useful. Rick, you had my history. Let me get my handy dandy questions. So, short answers: I have high risk decipher score. I have intraductal. I have cribiform. It's migrated into the seminal vesicles. I'm at UCSD. Have a couple smarty pants people advising me. Liss is standard surgeon. Radiologist guy who I will see here shortly. They're suggesting, and my questions will relate to this. So the standard process for me is they suggest to go on a hormone of some sort, Lupron perhaps. I don't know enough about that stuff, for 30 days, then have 28 days of radiation, and then stay on that because of the high risk, the testosterone suppression, for 18 months. So that's the pending what they think. So I had a PET scan. There is a hot spot on my rib, which doesn't make much sense to me. There are hot spots on my neck, but I have osteoarthritis in my neck, spine, and lower back. There doesn't seem to be anything from their decision that makes sense that's outside the prostate and the seminal vesicles. That's a nice idea. So my first question is there anything that I could do to exclude those potentially false positives? Dr. Liss, who is pretty much a smarty pants, does this both research and surgery at UCSD, said unfortunately not. I've had x-rays, I've had MRIs and stuff, so and he did recommend an x-ray targeting my rib, which when I went to a prostate summit conference a couple weeks ago, they said unfortunately the PET scans commonly, like 50% of the time, come back with some false positives, including of ribs, and they don't know why. So does that make sense to you guys?
We attended a session with Liz the other day. I was pretty impressed with him. He spoke to Brad Powers' cancer patient lab. Was this a PSMA PET scan that
Correct.
showed up these spots?
Correct.
And Ben, correct me if I'm wrong, but but don't they have some sort of PIRADS or density reading as well to show how intense the lesion is? Is that right?
But I presume they did that.
So that, well, I was going to ask what was the intensity of these readings, because I'm sort of drilling in on why they're not sure if these readings are prostate cancer or not.
And I'm a neophyte in all this, other than I thought that the PSMA targeted prostate cancer cells,
It
which
does.
it does, but there are also other targets apparently that look the same. News to me. And it looks at focus of blood flow. So if it has osteoarthritis, which I have in a couple places, it can appear to be a false positive. And I go, well, okay, so I'm going to go on this therapy for 18 months. And then if my PSA is still high, then we go down the path that we must have missed something. I go, I really don't want to go down that path. Well, okay, so that's a pending question. But what I really wanted to talk to you guys about, I do trust Liz on that because he seems to be very current. I'll continue to process this. If you have comments on the efficacy, the PSMA, and false positives, if you could put it in the chat, that might be the most efficient way to go. I do have an acupuncture appointment in about an hour and a half that I want to go to. But my real question relates to the kind of radiation that I might get. So is proton and X-ray radiation both equally effective at stopping the cancer and have similar side effects? I've been told that the X-ray radiation is far better than it was even 3 to 5 years ago. So they're comparable in efficacy of stopping the cancer, and they're similar in the magnitude of side effects. So I wanted to pose it to you guys because you know, in some ways, more than the MDs do.
So Larry Schuler's hand has been up for a while. No, I can't hear you. Larry, you're on mute.
Thank you. Is an image. Some people think it's better if I am. PSMA is an imaging process that detects a radioactive tracer. That tracer is attached to a molecule that attaches itself, gets taken up by PSA expressing molecules, but it also gets taken up by various other organs in your body. One of them is your salivary glands. So when I had my PSMA PET scan, my prostate cancer cells lit up, and my salivary glands lit up. My bladder lit up because this stuff starts processing out through your kidneys. So all these places lit up, but they are principally looking for high uptake in places where no cancer can be. The prostate cancer doesn't usually go to the salivary glands, but they know to look at the prostate and places like that. My second, I hope that answers that question about the PSMA PET scan.
And
Well,
for
my
what's
ears pricked up.
important is it didn't show up in my lymph system, which was nice.
That's good. Now, it'll only show up if you got tumors of a certain size. If they're smaller than that, they're called micrometastases, and it doesn't detect them. The imaging is not that good. It's pretty darn good, but it's not magic.
Correct.
The second thing, or the first thing, my ears perked up when you said Lupron for 30 days. Lupron, when you first start it, produces a testosterone surge that lasts for about 30 days before it suppresses your testosterone. So you might want to ask about that. Usually they'll issue a testosterone blocker at the same time as they do the initial dose of Lupron. But if you're only going to be on it for 30 days, heck, I would go with Orgovix.
And presumably somebody will tell me what this is, but what they might have said is you go on a hormone suppression for 30 days, then in order to lower PSA, and then go on radiation treatment. So which product, I don't know. There's what's her face, McKay, and other people at UCSD that I will see for advice on what kind of chemistry to
So
use.
you don't really
Or
need
the,
to do that. I mean, you don't really need to do that. The radiation oncologist should be fine on advising you on the ADT. It's sort of, it's I don't want to say it's below her pay grade, but the radonc there is going to advise you. Probably what they told you is you need to go on an ADT for it's usually about 60 days before radiation starts. Now, they can put you on a couple of different types of drugs, but be sure that if they're putting you on an agonist like Lupron or Zoladex or anything else, they've given you a buffer first. If they're putting you straight onto um, an antagonist like Firmagon, then you're in good shape. But we can work with you on that closer. I want to come back to something which is sort of bothering me. Where again do you think those PSMA? They said they might have seen something in the rib, and where else? Your neck?
yes, C3, 4, but I had an X-ray, and all the C's have osteoarthritis, fusion issues, lots of inflammation. So they discounted that based upon the presence of the osteoarthritis.
Yeah, but that doesn't sound right. Again, I mean, we don't hear that.
Yeah.
If it shows up on a PSMA, it's just like Larry said. It's attracted to a prostate cell. Osteoarthritis. I don't know, guys. The docs I'll ask, but osteoarthritis shouldn't be distorting a PSMA. Jack, did you have experience with that?
Yeah. I've got severe degenerative disc disease in my neck and my back, and when I've had 3 or 4 scans, none of it showed up as PSMA positive inflammatory. So the only places it lit up where I had definitive cancer, which on L2, pedicle, my rib, and my pulmonary subcarinal area. So I would be inclined to refute that hypothesis that all that inflammation is going to show up as
it doesn't
as a false
sound.
positive.
It just doesn't sound
No.
right, Wes. It doesn't sound right.
No, I don't think that's a false positive.
Dr. Jack, thank you. I think I would probably want to get that PSMA scan read again somewhere.
Okay.
I think that would be a smart thing to do. We could save you a long trip. We could recommend you get a second opinion on this, say maybe from a radonc or a GU medonc in Irvine at City of Hope, or or schlep up to UCLA. But I know that you want to do that, but
no, either of those is easy. Because your point is that it completely changes my likely path forward.
Exactly. Yeah. I mean, we need to know right now, and it doesn't sound like any of these spots are in a place where we could do a biopsy either. It's difficult to I don't know. It's difficult to biopsy. Is it difficult to biopsy those cervical vertebrae, guys? It is, yeah.
As I understand, and this relates to when I had staph infections, it's difficult to biopsy something and get the cells you want if they're just here and there. So it's a bit of a crapshoot, but it's a big deal. Like I said, I don't want to come back in 18 months and have it metastasize, so forth. So, and the Decipher score was like 67 or something. It was high, so it indicates the aggressive.
The
No,
idea of
and they were very amenable, Lists and everybody else, very amenable to second opinions. When you advised me early on with the prostate biopsy slides, sending them to Mount Sinai, we've moved past that, I think. But nevertheless, a second opinion on the PET seemed a possibility, although I didn't see the purpose until today listening to you guys.
What do other people think here? Len and Len, you got your hand up. Go ahead.
Yeah, Rick, I totally agree with you. I would think it's pretty unlikely that those cervical PSMA hotspots are false positive. The rib, I can go along with you on that. You mentioned 50% false positive. I don't think the rate is quite that high, but I have heard that PSMA is not terribly reliable when it comes to rib lesions. There are false positives there. And I think it was Larry was saying you have PSMA uptake in the salivary glands and the bladder and here and there. And that's all well known. And they just completely disregard that. So, you can't assume because you have because you have uptake, that's not even false uptake, it's real uptake in those areas that what you're seeing in the cervical area is false. I would be concerned about that, and the second opinion sounds pretty good to me.
And other than two opinions and then flipping a coin, what diagnostic tool is there? Well, let me ask the first question. Who else, if anyone, had what might appear to be a false positive in some bone? Because I have it in my left hip. So prior to the prostate cancer being diagnosed, I had a lot of pains. So in my lower back, my left hip, and in my neck, and the neck came on, and this sort of supports your view, the neck came on the last year or two. And I didn't play football. I have no good reason why I should have osteoarthritis the last 2 or 3 years of the magnitude I have, which is 4 or 5 pain.
So
other than I'm getting old.
What is it? Did you have you had a PSMA? Is there evidence of on the PSMA on your left hip?
I could find out. I don't know off the top of my head. They tended to focus on the cervical. No, the PSMA focused on C3-4, and the X-ray would have said C1 through 7 have osteoarthritis issues.
Okay, I mean they can see they can see that through other scans they're doing at the same time, but they don't see it on the PSMA scan. So my question is, on that PSMA scan, if your left hip lit up, that is a place we can biopsy.
Okay.
And we can confirm whether there are prostate cancer cells in your left hip. That's a great location for a biopsy.
Okay.
Now
I don't believe it lit up, but I'll remember that and follow up.
Okay. Now the other stuff that they're seeing may have been from other supportive scans that they did along with the PSMA, where they could see that.
And that, I don't understand what all is done with PSMA. I know they have CT. They combine a variety of things.
Yeah, they combine a CT usually just for location, but it's possible on that CT scan they were seeing some of that osteoporosis.
So I guess one question would be, when I talked to Lish literally yesterday, he was willing to order a rib-specific X-ray. I had a Heimlich maneuver once, and I go, it could have been broken. Okay, so that
I wouldn't be worried about your ribs. I'd be worried about what they're seeing in C3 and in your spine.
Right. So I had prior X-rays just because my neck hurt. So my question really to the crowd is, what kind of follow-up diagnostic, biopsy is iffy. What other might be appropriate for my neck?
FDG PET, Len, or Dr. John, or Dr. Jeff, or Dr. Jack, an FDG PET?
Or maybe put in the chat so the jargon gets recorded.
I mean, I think the first step is to get the second opinion, and we'll take this question then, because we do have to move along.
Excellent. And can you quantify the places in LA and Irvine that I might go? In the chat would be fine.
Yeah. Yeah, I'll put some
Appreciate
stuff
it.
in the
Thanks,
chat
guys.
for you. And by the way, Gary V, I put a link for you in the chat. The Wassersuch session that we did on estradiol that's worth watching. Just click on that; it'll open, and you can watch it later.
Okay, thank you.
Yeah, thanks, Wes. I'm sorry to cut you short. Steve Rue, you're up.
I'm going to defer my time for another meeting.
Thank you, Steve. Jay Mills.
Okay, yes, I have background is I had in 2018, I was diagnosed with high PSA contained. I visited with, had the fella at USSF who does um, uh, ultrasound, and it's so good. I can't remember his name right now. And then then I went to Mac Roach, and he advised to do HDR. Went with Shu and did HDR. But anyway, I've been and then I did IMRT, ADT for 22 months, I think 21 or 22 months, and COVID was hit, and I didn't go back for my last 2 shots monthly. I stayed on Daguerreotyx that whole time, and I did abiraterone for about 5 months, I think. Abiraterone and prednisone. And so I have been undetectable for 5 years. Then this past August, it came up to 0.1. Then 6 weeks later in, I guess it was October, did a point, maybe it was July and then August. Anyway, I came back and did this last fall, late summer, fall, and did an ultra sensitive and did a 0.96, and then came back in January and did came in at 0.2. So about 5 months doubling time is what it looks like right now, if all that's true. So now I'm scheduled for tomorrow to get a PSMA locally here in Chattanooga under the direction of my urologist who has been monitoring my PSA. And I have for my medoc, it was with Antonarakis, who has since moved from Johns Hopkins to the University of Minnesota's Cancer Institute, and I may go there. Would be the first. He would be the person I would reach out to, I guess, next. And Monday is when I'll get my results back from my PSMA. That's where I stand now. So I'm on the cusp of recurrence, is where I am, and I just wanted to share that with you guys, and maybe I'll be in the thick of it again.
So this was just an update. You have no questions?
The in terms of questions, I'm thinking about if I do have recurrence, I'm trying to see if what has changed in terms of recommendations. It would be that if I do come back with a number of spots, excluding ribs, perhaps. I had a rib before, and it was one that Mac, Roach, and the people who did the scan. That was that time when I had the scan done in 2018, I think it was. I had to go to UCLA to get it done because it was the guys from Heidelberg who were trying it in the United States on a clinical trial basis were doing it, PSMA, and they said, yeah, you've got a spot on your rib, but we don't think these mean anything, and because it is very faint. And then Mac said the same thing, but I'm going to treat it as if it is, and he did CyberKnife on it. So I wonder how now do they exclude faint ribs and faint things in terms of their count, in terms of was it the NCIS or something like that standards of the count to say whether or not you need to go on triplet therapy or not, and that would be one question.
I
But
mean, this is their job. This is what they're trained to do.
Right. And but then it also, in terms of, I guess the main question I would have for the group is Antonarakis available? I have not reached out to him yet, and I need to probably. Or are there other candidates that I should consider for some other reason? And I can travel anywhere, and I have pretty good insurance for the next 8 months until I go to Medicare, and I don't know if it's going to be any better or worse. I'm 64.
I mean, Antonarakis is one of the best. Why do you feel the need to go so far?
It's because I liked working with him, and I liked his depth and breadth of his knowledge, and his that's what I liked about him when I met with him. And I don't care about the distance. I don't mind traveling.
So in that case, why would you not go back?
I will, and unless I find someone else I want to check out and ask their opinion.
What was your initial treatment? What was your initial treatment?
It was HDR, high dose radiation. With I was consulting with Mac Roach, and he said the guy who does the HDR is Ai-Chow Shu at UCSF, and he's the one who did the plan. And then I'm trying to remember the Japanese guy's name.
Shinohara.
Shinohara. Yeah, he's the one who actually placed the rods. Actually, did the contour, the mapping of my prostate, and then he's the one who placed the rods in my prostate to do the plan that Shu had come up with.
And then they put you on ADT hormone, and then a vacation for 5 years.
Yes, that's right. Yeah, I became I got down to 0.02, and then I came out at 22 months. I was prescribed 24 months. I didn't quite finish that with exhaustion and in COVID. I didn't go back to the cancer center to get my last 2 shots. I think I did 22 months. I think.
Then 5 years on a vacation.
That's right. That's right.
That's pretty good.
So anyway, that's where I am. I really don't have any questions other than I'm trying to re-educate myself on what's the likely course of action that I should that you guys are hearing your doctors put you on. So thanks for still being here.
So Jay, I look, definitely Antonarakis is great. We all like him. You like him. You got to schlep up to Minneapolis, but you don't mind doing that. So he's good. If you wanted to focus on somebody closer to you,
right,
I'd probably send you to Dr. E, because we love her and she's fantastic. Eleni Evstathiou at Houston Methodist. She was 14 14 years at MD Anderson until 2 years ago when she moved across the street to set up a GU group there. She's super smart, just like Antonarakis. She's Greek, just like Antonarakis. She's a little more crazy and lively, I would say, than Antonarakis. I'm just looking for this picture. She said, I wrote her yesterday and said, am I going to see you at GU ASCO? She said, she wrote back and she said, there's nothing worth going for this year. So I said, oh, okay. And she sent me, she said, I said, I haven't seen a picture of you for a while other than looking over General Joel's shoulder. So she sent me this. I don't know if you can see this. I don't know if you can see it, but this is what she sent me. She was driving her Porsche through the streets of Houston yesterday.
Nice. Very nice.
And she sent me this picture. But seriously, she's great. I mean, I think if I personally, of all the docs, and I know a lot of them, and they're all great, but if I needed a doc, that's probably who I would ask for.
Yep.
And she's quite a bit closer. And she knows Antonarakis very well.
Right.
You know, she's being Greek, and I think they might have even been in med school together. I have a feeling they might have been in med school together. So if you're asking me, I would take a trip down. And the other thing that she's great about, and the guys will tell you, she doesn't keep you on a drug if you're having trouble with it. She'll get you on a monotherapy if you're not doing well. I mean, where's Julian? There he is. Julian, well, you want to say something? I go back longer with Jay than I do with you, Julian. I just want to tell you. And so you tell him, you say what you want to say about Dr. E.
She has great bedside manners. She'll listen to you. She'll peg you she'll take you where you need to go, and she listens to you. She won't do something that you're not comfortable with. You know, it's. I mean, I've never met a doctor like that that's enthusiastic about getting you well, and she got me well. You know, I'm in remission for almost 2.5 years, and I'm wondering if she doesn't like me anymore. She hasn't seen me, but I don't know why she wouldn't want to see me anyway.
All right. That sounds encouraging to hear of her.
You know, I mean, so Dr. E's one really good choice. Dr. Shmulewitz at University of Chicago is another great choice. I'm trying to think. Dr. George at Duke is another great choice. I'm trying to think of people that are a little bit closer to you, just, so you can sort of get there and back in a day if you fly in and fly out. That's probably, I would probably say, Chicago Research Triangle or Houston. All of those are reasonable alternatives, and they're all great docs.
How about New York? Is anybody particular in New York? Not really.
There's no one there. I mean, Morris is good, but he's not taking new patients, and I don't think he's better than any of those three. He's at MSKCC. There's nobody that really stands out for me at Weill Cornell.
What about Boston?
They got
Boston.
Boston, but nobody. Yeah, they are, but Sweeney's gone. He's back in Australia.
Right. Okay.
And yes, they have some. I can give you names in Boston, but I wouldn't take them over. I wouldn't take them over any of the ones that I've given you.
Right. Okay. Okay.
And then they're as good.
Yeah.
Yeah. You're not at a point where you need this kind of exquisite fine tuning of your docs.
Right.
You know, this kind of thing you see in the movies where there's just one specialist who knows what to do is not true in your case. I don't know if it's
Right.
true anywhere in our
Right.
world. So, yeah, any of these docs is more than adequate to treat you
Yep.
at this point.
Very good. Very good. All right. Well, I'll be back to report back what the PSMA shows and see what
Yeah,
you.
report back, and I'll send you, Jay. I'll send you Dr. E's contact info.
Very good. Very good.
All right, and if you
That's great.
decide to reach out to her, tell me, and I'll send her a note
Sounds
as
great.
well. All right, but
Sounds great.
we'll get you sorted. Yes, it looks like it's coming back. We'll deal with it, and we'll get you on ADT, on hormone therapy, for as short a period as we possibly can. But you see, that's another reason I know I said it, but just to repeat, another reason I'd go to E, because she's more flexible with how she prescribes hormone therapy than a lot of the other docs. A lot of them dive straight in with 2 drugs.
Yes.
If
Right.
you want, you can talk to her about, do I really have to do 2 drugs? Could I do a monotherapy? Could I do monotherapy darolutamide?
Right.
She'll listen to you. She may not agree with you, and she'll say, no, I want you to do 2 for the beginning. That's what
Yep.
she did with Julian. And
Right.
then, do we have any other Dr. E patients on here right now or not? I don't think so.
Okay.
I set you right. Did I set you right with Mac Roach?
Yes, you have. You did. Absolutely.
Okay.
And
All right.
it's
So,
sounding great with E too.
right. So if I set you right with Mac, believe me, well, I'll be setting you right with Dr. E.
Sounding good. Thank you.
Thank you, Jay. Dr. Jeff, you have been waiting to speak.
Yes, thank you, Ben. First, I want to comment to everybody on this call that I admire everybody who attends these sessions. I think everybody handles this with dignity. There's very difficult diagnosis with dignity and respect for everybody on here. But I would strongly urge that this forum not have any political comments made. My opinion, this is not the forum to make disparaging comments about the President of the United States or anybody else. We can all have our own opinions about our government, but I don't think it belongs on this AnCan meeting.
I think I certainly agree, Rick. Or maybe you can tell me what you're specifically talking about. Is something said at the last meeting?
That's correct.
Something said at the last meeting.
Are you asking me for a quote? Because I wrote it down.
Well, yes, because I.
Okay, so here's the quote.
Stay away from it, but I don't know who said what.
Okay, so here's the quote, and it was a comment made, amazingly, to a woman from Canada who called in last week, and the comments were being made about the Canadian dollar and the US dollar, and the quote was, well, the way this is going with the monetary stuff, with all this rubbish from our emperor.
Oh yeah, I said that.
Correct.
Yeah, I said that.
Right, and and my opinion is disparaging remarks about political figures, whether they're Republicans or Democrats, should not be included on this forum.
Okay, I would first say to you, it's a reasonable remark, but this isn't the right place to air that. So this should not have been aired right now. You should have taken it offline. You could have called me. You could have written to me. I'm sorry if I referred to. I refuse to say his name. That's my own personal, and I will retain that. But if you didn't like the term emperor, That's fine. I apologize to anybody who was offended by that. I've heard a lot worse. But I will say, I don't think that's a disparaging remark.
Really? Okay. Well,
Yes,
Roger,
really. I don't consider that to be the sort of disparaging remark. And the fact is, we're seeing it happen. So,
you were right.
But it was a political reference.
This is not
So
the place.
whether
Rick was
it's
right
a
when he said it.
we
This
can
is
disparaging
not the
discuss
or
it
place.
offline, Dr.
This is
Jeff.
not the place to
This
discuss
isn't
it.
the right place.
This is a
Given the
prostate
context, this
cancer
isn't the right
meeting.
place.
This
You
is
have
not
every
a
right to
menopause.
criticize me for that. I accept the criticism, but this isn't the right place to have this discussion. And I'm happy to talk to you about it offline. I will be a little more sensitive next time. But I got to tell you, it's real hard for me to be sensitive about somebody who is disparaging about so many people that I know and care for, who is disparaging about CDMRP. And I can keep going. He's not taking healthcare seriously in this country. He's not taking prostate cancer
Rick,
seriously in this country. And that's enough said.
Can we talk about cancer?
Yes, with pleasure. That this conversation should never happen. Dr. Jeff, what would you like to talk about with respect to
nothing.
cancer?
I'm done. Have a good night.
Thank you. Good night.
John M., you're next.
Thank you, everybody. And now for something completely different.
Yeah.
Right.
First of all, I want to say this call is amazing. This is my second time on here. It's a revelation, really. Second, so I want to say thank you to all of you. I want to say a special thank you to Rick. Thank you for your emails. Very, very instructive. So I'll give you a quick summary of my case, and I got 3 questions. I'm 64 years old. December 27th, I was diagnosed with Gleason 8. I sent it to Dr. Zhao at Sinai. He confirmed the diagnosis. My PSA was 12.5 on finasteride, so I think I should double it. Maybe that's 25. Decipher said high risk. I have biopsy 2 cores of Gleason 8, 1 core of Gleason 7, all on the left side of the prostate. PSMA PET scan on the 13th of January showed nothing outside the prostate. So the clinical plan, which I'm going to be reviewing with 2 different radiation oncologists in the next 2 days, seems to be radiation therapy, IMRT, brachytherapy, and 24 months of hormone therapy. I'm 6 weeks since diagnosis, and I feel like I'm in giddy-up mode. So here are my questions. Is there any value in the Prostoc test? Prostox. Second question, what should I be asking about when I'm meeting with these radiation oncologists about the treatment plan? I want to be like the smartest guy in the room and make sure I'm asking good questions and I'm understanding what they're recommending. And the third thing is who should be on my team and who should be on my medical team. So I'll take the first one. Any value in the Prostoc test?
So what are you looking to find?
Well,
What do you hope it'll
apparently,
tell you?
it'll tell me how good I'll tolerate ADT, but maybe it doesn't matter because I'm getting it anyway.
True
All
that.
right. Thank you. All right. Very good. So why get the bad news now? I'll just get it later. If I'm sitting down to go over this treatment plan with my radiation oncologist, 2 of them in 2 days, right? Don't ask. What should I be watching for? What should I be paying attention to? What should I be asking? I just want to go in there and be smart. Any advice?
Anybody have comments? Anybody who's had radiation? Ann?
Yeah, the first question I would ask is what kind of radiation they're recommending, and more importantly, whether they use a spacer.
Okay. And by the way, I chose radiation as a primary therapy. And I thought about surgery for a long time, but I decided radiation as a primary therapy. So thank you very much for the comment. I like the spacer. Brachytherapy, I was going to ask about, is it going to be a high dose brachy or low dose brachy? And given my case, does anybody have an opinion on that?
Larry Schuler, your hand's up. Oh, Larry.
Am I stumping the band here?
Oh,
Okay.
yeah. ADT is good. It is optional. So if you want to pass on that, discuss it with your oncologist. Frankly, I'm a fan of estradiol as an agent of ADT. Failing that, I would choose Orgovix, but it's expensive. But it has fewer side effects reportedly than Lupron. For me, the estradiol had far fewer side effects than the Orgovix that I was on. Other than that, talk to your oncologist about the side effects that you can expect from radiation. Most of them are temporary. Few of them are permanent, and they take a few years to show up usually. But I have
wait. Which ones are permanent? Which ones are permanent side effects?
Radiation can cause cancers, not prostate cancer, but other cancers.
Okay, I'm familiar with that. I thought there was a long term of the ADT. So okay, got it.
If you stay on ADT for a very long time, your testicles might just shut down and never start up again.
I'll have a conversation with them tonight about that.
Yeah. Again, Orgovix compared to Lupron, there was a study called the HERO study. The recovery of testosterone production when going off of Lupron takes months. Recovery when you start taking Orgovix takes weeks. So that's the HERO study.
Very good. HERO study. Very excellent. This is good.
I have an essay from a guy I found online. He goes by the name Kuj Hawk. I could send that to you if you want, but it's got two parts: rules to be a good patient and rules for my provider. Sounds like you might want to read that.
Yes, I'm going to send you my email address.
Okay.
And you can send me that. I will be a reader. So.
Okay. It's not very long.
Very good. Very good. Very good.
John, have you? I might have missed it, but have you had any genetic testing performed?
No genetic testing except the Decipher, which said high risk. It was a 7 out of 10.
So you haven't had the BRCA?
I haven't had any of that stuff yet.
Should I
get it?
Go ahead.
Should I?
If you're considering estradiol,
I'm an advocate of getting all the tests you possibly can before you decide your treatment.
Okay. I am 6 weeks past diagnosis in late December, and I'm like in giddy up mode. Like I want to go now. Am I?
That's a problem. A lot of people want to just get it done really quickly, and they sometimes, they might regret it. I don't know.
Okay.
That's right. Yeah.
Over treatment or treatment too soon is a problem with prostate cancer. People get alarmed when they shouldn't be. But then, what was your PSA and your score?
My PSA was 12.5 in late December, 12.5 with finasteride. So I think you're supposed to double it.
Yeah.
Gleason score.
Sounds like waiting might not be appropriate.
Yeah. Okay.
What's your Gleason score?
Gleason, I have 2 cores of Gleason 8, 1 core of Gleason 7, total of 15 millimeters.
Did they find anything particularly scary in the pathology?
Cancer.
It actually goes down from there.
I think he had a little extracapsular extension on my note.
Oh yeah. Yes, I'd had in the
in the yeah, the CT scan showed a little bit of extra prosthetic extension.
They did not say anything like cribriform intraductal.
No, nothing like that. Nothing like that. No.
He has a slow doubling time too. That mention about unnecessary tests. I was going to open up for discussion that prostox question, but now that I hear you guys talk a little bit more, I guess I think you're right. I mean, why do it? John doesn't want a radical prostatectomy. He wants radiation treatment. So I guess what on earth is the point of doing a test that's not going to have any influence over the treatment? And radiation side effects, delayed radiation side effects. It's not like if you're warned ahead of time, you'll know enough to look for them because they're symptomatic. You have blood in your urine, or you have diarrhea, or something like that. So I was going to raise that question again, but I think now that I hear some more, I've settled it in my mind. Not needed.
Well, if we're using SpaceOAR, I've been led to believe that those threats are still there, but minimized significantly. Is that true?
There's a little controversy about that. Some radiation therapists don't use it.
Okay. Any other genius attacks? Things I should be thinking about where they're laying out the whole plan?
Yeah, I was under the impression that prostoc test was about sensitivity to radiation and not about hormone therapy.
Okay, you're probably right.
It's radiation. It's for delayed side effects of radiation.
That's right. Yeah. I don't think it has anything to do with hormone therapy.
Okay, so I should get the prostoc test then.
No, I was saying that I didn't. Now that I think about it, I didn't think you needed it because you're going to get radiation therapy no matter what, and you're not going to miss anything by not getting it.
Well, it might cause you to reconsider your choice.
Well, yeah, and I've gone down this path, and I think just about everybody gets surgery. But as I've looked at the options, it just seems we get to the same place anyway. And I think radiation can have fewer negative side effects. I think, right?
Ben is right. If it might change your mind. So let's envision a situation where the prostox test says that you're likely to have some delayed adverse effects. Would that make you go to surgery? It would not make me go to surgery, but maybe it would make you or your doctor advise surgery. I wouldn't switch.
I'm going to ask about it, but I think I've made my decision on radiation. And what made it easy is I've been told there are no bad answers here. Surgery with a great surgeon, and I've been talking to Egner right here in Chicago. And so as long as you've got a good team on either way, you're going to be good. So I just kind of picked a horse. So I'll ask about that. Any other questions I should ask?
Well, I have a question for you. What happened when you went back to Egner and you said to him, I think there could be as much of a 60-70% chance that the surgery won't work?
Well, I haven't kicked that horse yet. Okay, so I haven't gone back to him yet to have that conversation. But so yeah, so that may take place. But right now, I know what I'm doing.
And certainly ask your radoc about the test. Ask him or her if you think it will have any value. May say that there's stuff you can do.
Yeah, so I don't know. First of all, great stuff, and I look forward to coming back here and sharing what I'm doing. I want to ask a general question. Really, I'm terrified about ADT. If I'm working out regularly, and I am, if I'm working out regularly and eating right, which I am I going to be okay on ADT, or is it going to knock me out? or we don't know?
We don't know.
Oh, thanks. Okay. All right.
Because
All
right. Everybody pretty much responds differently to ADT. And so you can't tell. Some people, it's like water off a duck's back. Other people, it's absolutely crippling. But if you're working out, you've lost weight, you're eating right, you're doing everything that's within your control. If you're reducing your stress, you're doing what's within your control. You can't really do much more.
Okay. All right, good. Thanks for the encouragement on that. So I look forward to coming back here and sharing my progress with the team. Okay. Thank you, all of you.
So
Really appreciate it.
actually,
Yes?
there are people lined up to still lined up to comment. Jimmy
Very
G.
good. I'll take all of them. Yeah, go ahead.
Okay, I know there's others. I won't take long. I won't comment on the estradiol other than to say that don't be surprised if it's difficult or impossible to obtain without some substantial effort. It's not standard of care, and it may not be offered to you. I'm not saying it's not a good idea. I'm just saying it's not easily available. It's not standard of care. The thing about the ADT, it may be willy-nilly, luck of the draw, whether you have side effects that are serious or not. What I always say is that it's pretty much borne out by a lot of people's experience is that the exercise is a critical difference. What is it that you're doing for exercise?
I'm going to the gym and I'm doing a weight training circuit. And then I do 30 minutes of jogging.
Okay, so all I can tell you, I can't tell, of course, when you say that, what that actually means. There's no way that you could put it into words where I could understand really what that is, and that's okay.
Legs, arm, core, shoulder.
Specifically. Yeah, I know, but like I can't tell the intensity, the volume. There's nothing in your words that can explain that to me, and nobody could. But what I can say is that as you go along, what's going to inevitably happen is that you will have some fatigue. You will probably not want to exercise. You will probably try to find your way around it. At least your instinct will be to find ways around it because fatigue is a real thing. And so is decreased muscle mass. Your metabolism slows. There are some inevitable things. So it's a pushing back thing. It's a swimming upstream thing. So that the more exercise you do, the more and more intensely that you're able to, I just recommend that you do push hard because it will be inevitably, no matter how fit you are, no matter how young you are, no matter who you are, the ADT presents a substantial challenge to your exercise regime. I just encourage you to be diligent. That's all.
Thank you. Excellent advice.
That's all.
And Jimmy will be here to get on your back if you don't follow this advice.
Wonderful, wonderful. All these hands, this is great. Keep them coming.
Jeff Markey, you're next.
I just another side of the ADT issue. I never had fatigue from ADT. It hits some people. I exercise a fair amount, but not near as much as you're talking about. And I've never had the fatigue. Some people do, some people don't. Have you had the Decipher test?
Decipher, yes. Decipher?
You said that was 0.7?
Yeah, it was like 7, yeah.
Yeah, 0.7.
Well, whatever it is. It's
Decipher's under 1. Okay. That just tells you how quickly you can be, you will become, it's likely that you will have metastasis return, that your cancer will return.
Great.
So
Okay.
0.7 is a little high on the side. But ADT, if you wanted to wait a little while, if you got on ADT right away, it will stop your cancer from growing. A lot of radiation oncologists want you to take ADT for a month or 2 or even 3 months before they do the radiation because it can shrink your metastasis. It can shrink what's going on in your prostate. Just something to know.
Thank you. Good.
Thanks, Jeff. Jim Marshall?
Yes. How about to be sure to get the baseline testosterone before you start ADT? Okay.
Okay. Thank you. Wonderful.
Gary V?
I did radiation.
I'm glad I did. I really didn't have a heck of a lot of choice, though. Roach said it initially that radiation was the only way to go, and my surgeon, Dr. Shigihara, and he said it was the only way to go. But based on my experience so far, I would not have gone with anything other than radiation. I think it's less traumatic overall to your body than surgery is. I think the recovery time, it took me maybe 2 months to recover from the radiation, but it was nothing like I've seen people go through after having prostate surgery. As far as the ADT, my biggest problem with ADT was mind fog. And that it wasn't so much physical as it was the mind fog. I did gain weight, and my blood pressure did go up, and I did get a few issues with arrhythmias, and just generally did not feel real good. It does get better though with time. I found myself becoming much stronger with exercise and just staying active. So I think the course you're on is a really good one. Dr. Roach doesn't think that uh, spacer
Sure.
does much as far as preventing issues with your rectum. Um, and I think most of us who've had radiation treatment, uh, despite the spacer or anything else, still have some problems associated with that. I don't know that there's any way you can get around it with radiation, but definitely go someplace that is well versed. Get get somebody that really knows what they're doing to put together your initial treatment plan. It does determine whether or not you're going to be able to survive this.
Excellent. Thank you, Gary.
Thank you,
Is there
Gary.
any way to determine if you're predisposed to gynecomastia?
No, that's another that no, I don't know that, and so I actually want to bring that up with them tomorrow. It was on my list of questions.
Because
I don't believe there's a prediction of who.
Go ahead.
I don't believe there's any way to predict who's going to get it and who's not.
No, but there is a simple prophylactic
Yeah.
Move to take if you're going to go on an estrogen-based hormone therapy, or you have some concern. Some people respond. Some people get gynecomastia even from being on the regular testosterone-based therapies, because as Larry pointed out, they also restrict estrogen. They also affect the estrogen production. You just get a shot of radiation to your chest, which is not supposed to be at all damaging before you start.
Okay, very good. I'm going to bring that up tomorrow as well.
So what is your position on who's going to do this? Are you still thinking that you want to get it done locally?
So I've got two appointments. One tomorrow with my doctor, Dr. Lee, who did his residency at the University of Chicago. And then Thursday, I'm seeing Muzamil Arshad, who is a radiation oncologist at the University of Chicago. And so I'm doubling up there, and they're both going to give me a treatment plan. And Stanley Liu, I couldn't see him till mid-April, and I said I'm not waiting till mid-April. And so that's my plan. Although if I think I've got my bases covered between the two of them. I think both are competent. So I'll really work Muzamil Arshad at the University of Chicago on my options.
Oh, there's still hands. I'm sorry. Dan.
Yeah, last year I was in your predicament, and based on the doctors, they wanted to do surgery. I scheduled it twice and canceled it. Finally, read a few books recommended by Jim Marshall and others here, and got into radiation therapy and hormone therapy. Unfortunately, with the hormone therapy, they put me on Lupron, but they didn't want to do bicalutamide beforehand. I had to force them on that. I went easily through the radiation and the hormone therapy until just this past December, And I started out this whole session here indicating some of the side effects I'm going through. So I think you're in a pretty good situation. You're already aware of some of the side effects down the road. But
Yes.
like everybody's saying, everybody's unique.
Okay. Thank you, Dan. I appreciate that. Thank you.
Thanks, Dan. Jay Mills?
Yeah, I just wanted to, in addition to testosterone before you go on ADT, another one to get would be a baseline bone density scan.
Okay.
Good idea.
DEXA.
Yeah.
DEXA.
Okay. Okay. I'm making lots of notes here.
Gary V?
Start taking the calcium and the vitamin D now.
Okay. Okay.
Because ADT will deplete your calcium levels.
Good. Okay, good. I'm already taking vitamin D, so I just got to add the calcium.
How many milligrams or micrograms?
I don't know. I don't
He
know.
said vitamin D, not B.
Oh, he said
D.
B as in I'm
No, D.
I'm taking
D.
vitamin D. I'm taking one of the little capsules.
The most common recommendation, and please everyone correct me, but the most common recommendation is over 5,000 IUs a day.
I think
Okay,
that's
Rick, you
high.
disagree?
Not my pharmacist.
Yeah, I disagree too.
2,000 about for most.
2,000.
Also, you should be taking citric calcium. I've been told by a pharmacist specifically to take that one. And a lot of times the pills are when you look at the percentage, you're supposed to take 500 milligrams at least twice a day. A lot of times the citric calcium requires you to take 2 pills to get 500. Just keep an eye on it. Other types don't require 2 pills.
So 5,000 is recommended if you are low to begin with. So if you're at let's just say, and I think I was somewhere around 20. I was really low. I can't even remember, but they'll put you on 5,000 daily until you get to your level. But what is recommended is that you check your vitamin D on a regular basis and you adjust the amount that you take to keep it at a level that is probably somewhere around 45 to 60. So there is no recommended amount because you change it according to what your actual level is. And you should be testing it regularly.
Great insight. Great insight. Thank you.
Jack, your hand is up.
Different recommendations. Some people say 50 to 80 blood level is ideal, and whatever it takes to get there. Some people are kind of, very uncomfortable with 5,000. Other people are comfortable. Depends on your oncologist. As far as calcium is concerned, most people say dietary is better, not pill. Pill, you can overshoot your mark, end up with too much calcium. If you have metastatic bone disease, that could be a little risky. So I say continue to do it dietarily, yogurt, milk, and stuff like that, whatever you choose, and limit yourself with the supplements of calcium.
Okay. Very good. Should I add a nutritionist to my team?
Oh, yes.
Okay.
Well, you'll get one if you'll get one at University of Chicago. They're almost certainly going to have a nutritionist as part of the Comprehensive Cancer Network, Cancer Center.
Okay, good, excellent. All right.
Jack, did you wanted to say more? Your hand was up again. Okay.
My hand's not up. My hand's not up.
Took it down. Okay.
Hey, once Dr. Jack figured out how to put his hand up and his hand down, there's no stopping him. He used to be great. He used to be just wave at the camera and do everything. Now he's got his hand up, he takes his hand down.
Takes me a while to learn sometimes.
Jeremy, it's nice to see you. You may have this is this isn't the early meeting. Did you did you come late by accident or did you have something urgent? Because
Good,
we're
good,
just
good to see you, Jeremy. This meeting starts at 4 o'clock. Oh, 3 o'clock your time. 3 o'clock your time.
so it's hello and goodbye for you, Jeremy. Sad to say.
Although
Okay.
I just want to tell you, Wes just left, but we recommended Percy Lee and Sandy Lou to Wes for second opinions on stuff. He's down at UCSD, so we've been thinking about you, man.
Yeah. Yeah, I'm gonna send you a message offline. I'm my surgeon, my spine surgeon. It's a long story, but I need a referral out in Austin, Texas, for him. But I told him to join our group, so he's gonna try to sit in on it.
Okay. Okay. It looks like we're done. Ben, if you can hold on for a sec so I can sort you out on MailChimp.
Ah, yes.
And maybe Len, if you can hang on for a minute, that would be great.
Otherwise, as Rick
And
would say,
I do want to, before you turn off the recording, I do want to apologize. The referring to a certain person, as I did, I still don't think it's particularly disrespectful. I think it maybe touches a nerve if you call a certain person the emperor. But I will do my best. We will all do our best to keep the politics out of here. But there's politics and politics. I mean, to refer to somebody as the emperor. But I get it, and I guess I need to be a little more sensitive.
You
I'm
don't need,
sorry.
I'm working for him right now, Rick. Okay.
Are you?
Yes, I am.
Oh yeah. Okay. Well, you'll tell me more. You'll tell me more about
Begrudgingly.
that. You'll
Ray,
tell
it's
me
not so
more.
bad. Just don't call him dear leader. I think that would probably offend more. Dear leader is what you don't want to. You don't want to use that one.
all right, all right, all right, all
Well,
right.
Rick, in my opinion, it's no big deal.
Thank you. Well,
Not the,
it obviously hit
I
a
am
nerve.
I'm not.
subject to recall in 3 days in the Air Force, so he's still, anyone up there is my commander in chief, and I have gone through them all, starting with Johnson. So, hey,
Okay,
I'm
no more of this. We are, as Rick would say, we are done and dusted.
Yes.
I will end the recording. It's been nice to see you all. Thank you all for coming.
Right.
Oh, great meeting.